Welcome to Pediatric Grand Rounds. Before we get started, just the usual reminders from me. Please stay muted during the presentation. When you have questions or comments for our speaker, you can enter them into the chat with everyone at any time, and I will read them out or give you a chance to unmute or both at the end of the presentation. You'll be getting an evaluation by email from our team this week. Please make sure to fill that out for us. It helps us with planning future grand rounds. And finally, our planners for grand rounds have no relevant financial relationships to disclose. And now I have the pleasure of introducing Dr. David Suskind, who is Director of Clinical Gastroenterology here at Seattle Children's Hospital and Professor of Pediatrics at the University of Washington School of Medicine. An expert in intestinal diseases, Dr. Suskind has focused much of his energy into clinical care and research for inflammatory bowel disease. Dr. Suskind is physician lead of Improve Care Now, a national quality improvement collaborative with over 68 other children's hospitals, whose main objective is to improve the quality of care for patients with IBD using standardized quality improvement methods. Thank you so much for being here, and welcome to Dr. Suskind.
Thank you so much for having me. It's such a pleasure to be here to talk with all you, at least virtually, and to talk about something that I'm very passionate about. Today, I'm going to be talking about actually really a miracle therapy, which has the potential to save millions and millions of lives. And no, it's not a vaccine, and no, it's not a newfangled medication. What it is something that we've known a lot about for millennia: diet, the foods that we're eating. And we know that diet is integral to overall human health, and it plays a very large role in human disease, with diets associated with increased morbidity in certain conditions, as well as increased mortality worldwide. And this is just one example. This is a paper from The Lancet from 2019, which looked at diet and its association with mortality rates, and specifically looking at the different types of diets worldwide that are attributed to these different causes. Now, I wish I could talk about all aspects of diet, but within a 45-minute grand round, that is near impossible. But I am going to talk about a very important aspect of diet and nutrition. That is diet and nutrition in immune balance. And really talking about the learnings that we've had in inflammatory bowel disease about how diet interacts with the immune system, and how we can modulate our diet to actually improve IBD, as well as other aspects of life. The very interesting component to this is 10 to 15 years ago, if we talked about diet in what was felt to be an autoimmune disorder, we would, for lack of a better term, be poo-pooed. We would be told that has nothing to do with disease process itself. But in fact, with our research, with research from others, that feeling, that belief system has actually changed fairly significantly in medicine, and now it's an active discussion within the world of IBD and also gastroenterology. So why should we focus on diet? Why should we focus on diet specifically in inflammatory bowel disease? Well, there are many reasons too. And if you look at the pictograph on the left-hand side, you can see a world map, and you can see that the incidence of inflammatory bowel disease has steadily increased over the last century plus. And what that means is that IBD, although having a genetic component, is really an environmental disorder or a disease. You can see that as the world became more industrialized, especially in Europe and in North America, you can see that steady rise of the incidence of IBD. And when you look at other countries that were non-industrialized, but now becoming much more industrialized and uh, incorporating Western diet and Western lifestyle, you can see that that incidence of inflammatory bowel disease again increasing. And this is not only true in adults, but the pictogram right below the map shows the increase in pediatrics. And this is over the last 20, 30 years, we're seeing this increase as continuation of dietary trends continue. Another really important reason to focus on diet is that although we have really good medications, really effective medications, they're not 100%. They're not 100% in terms of efficacy for all individuals, but they're not 100% for the individual themselves, meaning that individuals may respond partially to certain medications, but still have symptoms or elevated inflammatory markers, which need some type of concomitant therapy. Now, if you look at that pictograph on the right, this is one of the kind of hallmark studies in IBD. It's called the SONIC trial. And in this study, individuals went on to infliximab and azathioprine, two potent immunosuppressants. And what you can see is, despite being on two potent immunosuppressants, only 56% of individuals went into clinical remission at 26 weeks, leaving a very large gap in terms of overall efficacy. The third major reason to focus on diet is that medicine, and we all know this, is expensive. It's not only expensive for the health system, meaning that it costs for patients to be seen as well as hospitalized, and the surgeries and other aspects of care that we provide. But it's also very expensive for the individual in terms of time lost, in terms of the medication therapies. Some of these medications can cost on average $30,000 per year per patient. So it has a personal cost as well. And for all these reasons, we need to have better therapeutics, and diet is amongst those. So what is inflammatory bowel disease? And I'm sure most of everybody on this grand rounds knows what IBD is. But it's a disorder, just as it sounds, of inflammation within the bowels, within the intestines. And there are two main types. There's Crohn's disease and there's ulcerative colitis. And we won't talk about the specifics today, but to note that both of these are immune dysregulations. And what that means is the immune system, that part of the body that is there to protect us, has gotten confused. And instead of fighting off infection, it's now attacking the bowels. And we think there are two main reasons for this. One, the intestinal microbiome, which is made up of likely 100 trillion different bacteria, as well as mucosal integrity, which is that lining that keeps those 100 trillion bacteria away from the rest of the body. And so how does diet impact that? Well, to know how diet impacts it, it's really important to know what the risk factors for IBD. So as I had mentioned before, there's a genetic component to IBD. So there are over 260 different genes associated with IBD. Now, as you know, that if this was only a genetic disorder, such as cystic fibrosis or other, that the overall incidence would likely stay very similar over time. But we know that this is really an environmental disorder, meaning that it's impacted by the things that have gone on in your life in the past, as well as currently your environment. And there are two components to that, or two large components to that. One is antibiotic use. The other is the foods that we eat, diet. And what we think occurs based on both antibiotic use as well as diet is that the microbiome becomes dysbiotic. And what that means is it becomes more pro-inflammatory, more likely to instigate a response from our immune system. Another significant change is mucosal disruption. Again, that barrier system that keeps out the 100 trillion bacteria breaks down. And then finally, you have an immune activation and inflammation occurring, which results in what we see during endoscopy and colonoscopy. You can see here on this endoscopy that the lining of the GI tract is inflamed and ulcerated. And all of this is impacted by diet. So let's dig down a little bit deeper in terms of those different aspects and how they affect IBD and how diet may affect each of those aspects. So first, the microbiome and IBD. As I had mentioned before, there are over 100 trillion different bacteria which reside in each of our GI tract. And these bacteria are different, and each of us have different bacteria at different concentrations within our GI tract. In inflammatory bowel disease, the pro-inflammatory bacterium, such as Enterobacteriaceae, are increased, and bacteria which are anti-inflammatory, such as Fecal Bacterium perniciae and others, are decreased. So there's a shift in the ratio. In addition, there's decreased diversity of the bacteria. So you have decreased types of bacteria overall in the IBD GI tract. And the ones that are there are usually what we call mucolytic, which means that they break down the mucus layer and again get closer to the epithelial cells, which instigates the inflammatory process. But you may be asking yourself, well, that's all interesting, but how does diet impact the microbiome? And when we think about diet and the microbiome, it's probably easier to think instead of bacterium, thinking of multicellular organisms. So here we have a tiger, a dolphin, a panda, a gorilla, and a cow. And if we were to feed all of these animals hay, we would not be surprised that maybe the dolphin would die and the tiger would die, and we'd have a plethora of cows. So now you have to just change those organisms to bacterium and change the hay to the foods that you eat. Because when we eat the foods that we consume on a daily basis, we're also feeding those bacteria. And because of that, you're actually shifting the bacterium within the GI tract. And that shift is actually fairly rapid. So you can, if you change your diet just in one day, you see a very large shift of what types of bacteria are residing within your GI tract. And there are many studies that highlight this, but this is one that I particularly like by Rothschild and colleagues that really emphasize the dominance of environment over over genetics in shaping the gut microbiota. And in this study, over 1,000 patients were enrolled, and this study was done in Israel, and individuals from different ethnic backgrounds, Ashkenazi Jews who are European Jews, Yemenites who are from Yemeni, individuals from other Middle Eastern backgrounds, individuals from North Africa, and individuals who are Sephardi, which are Spanish and African Jews. And they looked at their genetic backgrounds and they took an in-depth exam of their environment. And they noted that environment, again, impacted the microbiome most, with diet being a major component of that. So another really important aspect of IBD and the development of IBD is the breakdown of the mucus layer. And in this pictogram, you can see the epithelial cells on the bottom, and on the top, you can see little red dots, and those are bacterium. And in the middle, you see this black layer, and this black layer is your mucus layer. And this is about 9 microns thick, so invisible to the naked eye. And you can see that a few bacteria get within it, but the vast majority stay out of it. Now, we know many things can affect this mucus layer, and diet is definitely one of them. There have been many studies in the basic science realm looking at different food sources and their impact. So we know that emulsifiers like maltodextrin or CMC or polysorbate 80 affect this. A high-fat, high-sugar diet affects the mucus layer. Carrageenan, caking agents, and microparticles. And all of these things are a part of the foods that we eat on a day-to-day basis. And you can see here the major shift, and this is a study that looked at maltodextrin, but you can see that just by giving maltodextrin instead of the controls, which were water in this study, you can see that the bacteria get much closer to the epithelium and actually abut the epithelium. And this allows for the immune system to interact much more with the bacteria and instigate an inflammatory response. And the most important aspect of our diets and the changes in the Western diet really focus on a high-fat, high-sugar diet. And this is just another study by Martinez Medina, which looked at a high-fat, high-sugar diet in CBAC10 mice, which are mice that are predisposed to developing IBD. And what they were able to show that it did indeed increase E. coli in the GI tract, but it did other things as well. In this pictogram, you can see that a high-fat, high-sugar diet increased claudin-2. And claudin-2 is a pore-forming protein in the GI tract. And it literally leads to a leaky gut. So high-fat, high-sugar diet leads to this leaky gut that we sometimes see in IBD. In addition, we see a significant decrease in Muc2, and Muc2 is a major component of that mucus layer that, again, keeps out the 100 trillion bacteria from the rest of our body. So again, just emphasizing the impact of the foods that we eat on intestinal health. Now, there are also direct effects on the immune system from diet. And these have been well described in terms of having pro-inflammatory or anti-inflammatory effects. So some pro-inflammatory foods include wheat germ gluten and amylase trypsin inhibitors. Anti-inflammatory foods include isothiocyanates, polyphenols, proanthocyanins, and many others. And a really good way of assessing if something may have an anti-inflammatory effect is really looking at the color of the food. And most that have vibrant colors usually are anti-inflammatory as well. So all of that might be fine and good from a theoretical standpoint, but do we have actual evidence that the foods that we eat or the nutrition that we ingest has an impact in inflammatory bowel disease? And in fact, we do. We have had this knowledge for 50 plus years that something called exclusive enteral nutrition, or EEN, works extremely well in Crohn's disease. And this is actually the mainstay nutritional therapy in IBD and specifically for Crohn's disease. What it is taking in formula and formula alone for about 8 to 12 weeks. And you take in no other foods or drinks except for water. And this can be delivered either orally by just drinking it or via nasal gastric tube. And this is a pictogram of some of the IBD team, and we're celebrating IBD Day with support of our patients and placement of nasogastric tubes in all of us, and taking in our EEN because we are so supportive of this type of therapy and the benefit it gives. Now, you may say, well, what does that mean, a positive effect? Well, there have been many studies of using EEN in pediatric Crohn's disease. And this is actually a meta-analysis of studies that have been done, and it compares steroids to EEN. And when we compare steroids to EEN, and steroids are the mainstay medication that we use to bring patients initially into remission, but when we compare the two, we see that both of them work equally as well in terms of getting patients into clinical remission, as well as normalizing inflammatory burden. But EEN does something else. EEN has a major impact in IBD that steroids just don't have. And this is a study by Borelli and colleagues that really emphasizes that point. What you can see here in this pictogram is the clinical effect of both steroids and EEN. And you can see that based on something called the Pediatric Crohn's Disease Activity Index, which is an activity index for Crohn's disease, that patients clinically improved the same on steroids and EEN over time, so equal. Same thing with the inflammatory markers. You can see this normalization of CRP, as well as this normalization of sedimentation rate, the two main inflammatory markers we check in IBD, and that these inflammatory markers are no different over time, whether you use steroids or EEN. But what was really different here is what happened with mucosal healing. With steroids, you can see that there is not really a significant difference in mucosal healing. There are some individuals that did have mucosal healing, but a lot of patients actually had no real shift in the healing of their GI tract. As opposed to EEN, where you see significant mucosal healing before and after with the use of. So by using a nutritional intervention and a nutritional intervention alone, you get better healing of the GI tract, but you also get improved nutritional outcomes and improved growth, something that steroids do not give. And you may be asking, well, if it makes patients feel better overall, why do you see a difference in clinical outcomes in terms of, or not clinical, mucosal outcomes in terms of therapy? And this may be one reason why. This is a follow-up study by Pigneur and colleagues from Paris, where they looked at the use of EEN versus steroids and looked at the microbiome. And what you can actually see here is there's a fairly significant difference in the outcomes of the microbiome. So this is prior to therapy, and you can see that the microbiome shifts in a different direction with EEN versus steroids. And this may be one main reason why we see a difference in the healing rates. And the therapy has actually been shown to be quite effective in pediatrics as well as adult medicine. And now there is some controversy with adult Crohn's patients in terms of whether or not it works as well as steroids. But this may be more related to poor compliance than poor efficacy. And the reason why I say that is there are two studies, one by Akata and one by O'Moraine, which looked at the use of EEN, but had patients place a nasogastric tube to take out the question of compliance. And in those two studies, the efficacy was equal to that of pediatric studies, so around 80%. So you may be asking, well, that's wonderful, but you can't actually stay on formula forever. And are there actual dietary interventions that we can use to show improvement in IBD? And there are, and I'm going to highlight a number of them here. But one of the most impactful studies recently is coming again out of Israel, looking at something called partial enteral nutrition and the Crohn's disease exclusionary diet. And patients came into the study with active Crohn's disease, and they were placed on either the Crohn's disease exclusionary diet with 50% modulin, which is a formula that we use to treat Crohn's, or 100% modulin, i.e. EEN. So they were placed on either of these two dietary interventions and watched for 6 weeks. At the 6-week time point, and this is actually quite important and quite interesting, and I'll show you the results shortly, but at the 6-week time point, the CDED group increased their whole foods diet and went down to about 25% modulin by caloric intake. The EEN group went on, again, a 25% modulin and a free diet. So just the regular foods the patients would normally eat. And they were reevaluated at 12 weeks. And this is what happened. When we look at the 6-week mark, what we see is that there really wasn't a difference between the two groups. So EEN, 100% EEN, was very comparable with using partial enteral nutrition, 50% formula, with a very healthy diet, the Crohn's disease exclusion diet. So we see clinically, they seem to work equally as well. But something happened. Something happened at the 12-week mark. When patients went on to, patients in the EEN group went on to a regular diet, we see the remission rates shift downwards fairly significantly to about 56%, while the Crohn's disease exclusionary diet, the healthy diet with partial enteral nutrition, increasing. So again, showing us that the foods that we eat have an impact on disease itself. And it's not only symptomatic relief or symptomatic or symptoms themselves, it's actually the objective markers of inflammation that were changed as well in this study. So here you can see in the blue the baseline calprotectin, and a calprotectin is kind of like a stool CRP. It's an inflammatory marker that we often measure in Crohn's disease and ulcerative colitis to track our patients. And in both EEN and the CDED group, they were significantly elevated at baseline. And at the 6-week mark, again, you see a major shift downwards of the calprotectin. But at the 12-week mark, while we still see continued improvement in the calprotectin for the CDED group, eating a healthy diet, we see a significant bump back up of the calprotectin on the EEN group, which started eating a regular diet. So again, emphasizing the importance of diet in not only symptomatic control, but also on the inflammation itself. So you may now be asking yourself, well, are there just dietary therapies that may work by themselves without the use of formula? And indeed, there have been many studies, and these are just some of the different diets that we've looked at in inflammatory bowel disease, but I'm just going to focus on 2 of them. We're going to focus on the specific carbohydrate diet as well as the Mediterranean diet, because these have been the best studied thus far. So to talk a little bit about the specific carbohydrate diet, this is a diet that we've been studying here at Seattle Children's for over a decade. And it's a diet that actually has been around for over a century. It actually was started by a pediatrician at Columbia to treat celiac disease before we knew that celiac was just related to gluten. And this diet restricts all grains because he had noticed that when grains were restricted, celiac patients did better. So it restricts all grains. It restricts sweeteners outside of honey. It restricts dairy products outside of hard cheeses and yogurts, and it restricts food additives. What it really focuses on is the whole foods diet, including fruits, vegetables, meats, as well as a yogurt that's fermented 24 hours because it removes the vast majority of lactose. And we started studying this when a patient actually came up to me and said, this diet, it works. And as a clinician, I was skeptical, but we dug a little bit deep, and we did see that for some patients, it seemed to work. And so we started our research with just small retrospective studies, and then interviews, and then actually built it up to prospective studies, and finally a multi-center study as well. And this is one of our initial prospective studies where we use dietary therapy to treat both pediatric Crohn's disease as well as ulcerative colitis. And we brought kids in who had active disease, as noted by an elevated PUCI or PCDAI score. And we placed them on the diet and the diet alone. So no change in medical therapy, no other interventions, and no changes within dosing of the medications that they may have already been on. And what we did is we followed them over time after they initiated the diet. And what you can see is that they symptomatically improved quite dramatically over a 2 to 4 week period. And for the majority of patients, it seemed to work well. But we also wanted to see if it impacted the inflammation, because that's a very important component of IBD. And sure enough, we see that both as sedimentation rate and C-reactive protein improvement and normalization for the majority of patients. But we also wanted to know, why would we see the things that we saw in terms of clinical and biochemical reactions? And so we did microbiome analysis for the majority of patients. And this is just one example of one of the patients. And you can see in this patient, they had a large amount of E. coli and Ruminococcus canavis, so about 12 and 15% of their microbiome. And that as time went forward, you saw a significant shift downwards of the type of bacteria, a significant shift downwards of these pro-inflammatory microbiota. And we saw a shift in the vast majority of our patients, but because microbiome is so individual, we saw different shifts for different patients and different organisms in different patients. But again, emphasizing the impact that the foods that we eat in terms of the bacteria within the GI tract. So we then moved forward. We asked ourselves, well, the SCD, the specific carbohydrate diet, is a diet which removes a lot of foods, which makes it sometimes hard to follow over time. And we wanted to see if we could liberalize the diet at all and get similar or the same outcomes. And so we looked specifically at our active Crohn's disease patients and did a blind diet controlled study. So patients as well as providers were blinded to the diet that the patient was on. And we did this by hiring a study chef who prepared all the food for the patient. And they integrated the different dietary components in a similar fashion for each patient. So the three main diets that we studied in this initial diet controlled study was whole foods diet, a specific carbohydrate diet, as described already, and a modified specific carbohydrate diet, which looked at, or which included oats and rice, so just some of the grains that were excluded. And what we found was very interesting. We found that clinical response seemed to be very similar in the different groups. So in the strict, the modified, and the whole foods, patients seemed to feel better when they just ate healthier foods overall. Now, we also looked at inflammatory marker, the CRP, and we did see a shift downwards for the three groups, but the whole foods diet, the shift was not as great as the other two. So then we wanted to move forward because all of our initial single center studies were smaller. And so we moved forward with Cincinnati Children's and did the produce study, which we actually recently finished and has now been published in the American Journal of Gastroenterology. And what this study was looking at a patient's usual diet and comparing it to the SCD or a modified SCD when they had active Crohn's and ulcerative colitis. Now, this study went on for 32 weeks, so it was a very long study, and it was that long because it was a very unique type of study. It's called an N of 1 trial, where the patient is the study themselves, and the intervention or the patient modifies their intervention over time. And so we compared, again, the usual diet to the SCD, to the modified SCD, and back again. And we collected data via customized app, which let us know how patients were feeling. And then we also studied fecal calprotectin as an objective marker for inflammation. And as, again, we talked about the SCD, in this version of a modified SCD, given the work we had done prior, we increased the foods that were allowed. So again, allowing for rice, oats, but now with sweet potatoes, maple syrup, and unsweetened cocoa powder. So we're going to go over the results shortly, but I'm going to show you how to read the results first because this, because it's an N of 1 study, we take the results and develop a probability figures for them to tell us if the diet is actually having impact overall or not. And so when you look at the screens that I'm going to show you, just notice that the first column is for patients who were full completers, so were able to finish the entire study. Those that were early completers, so at least finished 2 of the crossovers, and those who were withdrawals. And you can note that there were a fair number of withdrawals in this study. And this simply denotes the difficulty that changing a diet can be for any of us, and sometimes also that the diet itself did not work. So the next thing I want everybody to look at are the rows. So each row compares 2 different diets. So the top row compares the SCD to the baseline diet and the likelihood that it had impact. The second row, the MSCD versus baseline diet, and the bottom row, the SCD versus the modified SCD. And then finally, each column represents a different patient. And you can see they're divided as Crohn's disease, ulcerative colitis, but there's also a column that represents all of the data combined. And then finally, each column again represents a different patient and the probability that one diet is better than the other. And what we're really looking for are the black bars, notably over the 50% mark. And so this is the GI promise measure that we used for our patients. And what you can see here is that there are a lot of black bars that are over the 50% mark. And so you see with the SCD versus baseline diet that overall the dietary intervention seemed to work much better than their baseline diet in terms of symptomatic improvement. So abdominal pain, diarrhea, etc. The MSCD was also better than baseline diet, as denoted by the number of black bars. And the MSCD versus baseline, the SCD versus MSCD, we don't see a lot of black bars because they seem to work equally as well from the majority of patients. And we see a very similar figure when we are looking specifically at IBD symptom scores, so PUCI and PCDAI. But again, with IBD, we're not only looking for symptoms, but we also want to make sure that the inflammatory burden is better. And this is a very messy slide looking at all the fecal calprotectins for all the patients. And each fecal calprotectin represents a different time period. But when we aggregate these calprotectins, you can actually see the shift of inflammatory burden fairly well, especially for the full completers, where you see calprotectins in the 1200s and them coming down to about the 250s, 300 mark. And again, this is signifying the impact on the inflammation itself. And we saw this when we did individual groups, but also when we compared the entire groups or included all the aggregate results together. So at the end of the study, those patients who were full completers, the vast majority actually stayed on a dietary therapy, with the majority staying on the modified SCD, given the clinical and inflammatory improvements. So we also see this in adults, and this is a study by Jim Lewis, and we here at Seattle Children's were a part of it, despite it being an adult study, just given our work in the SCD space. So this study looked at the specific carbohydrate diet and looked at it compared to the Mediterranean diet in active Crohn's disease, or specifically Crohn's disease with active symptoms. So they were really looking for symptomatic remission in this study, as well as reduction in biomarker inflammation. And again, this was a 12-week study. Patients came in with active symptoms and were given food for 6 weeks. And in this study, food was provided again for that first 6 weeks, either Mediterranean or the SCD, and then they were evaluated. And then the second 6 weeks, patients made their own foods. What you can see in terms of response is that both diets seem to work extremely well for patients with active symptoms. You can see that symptomatic remission was equivalent in the two groups. Clinical remission, again, it's a different scoring system, but clinical remission, again, was similar in both groups. So just by going to a healthy diet, patients improved how they felt. We saw about a 30% of the patients change their fecal calprotectin in a significant way. We also saw a change in CRP, the other inflammatory marker we check in Crohn's disease, but to a lesser extent. And after 12-week mark, where patients were doing this on their own, we again see continued clinical improvement and a further improvement maybe in the calprotectin, not as much for the SCD group, not as much for the Mediterranean group, but increased efficacy in terms of CRP response at 12 weeks. So how do we utilize diet in our IBD clinic in our therapies today? Well, really, it's either going to be patient-driven because families sometimes are hesitant to use medication therapies, as well as sometimes disease-driven, where the patient is partially responding to medications, but not completely. And we use it both in induction in terms of getting them into remission, as well as maintenance therapy. So I'm going to leave you with a visual impact of how nutritional therapy can affect patient outcomes. And this is a young man that is no longer a young man. He's now a young adult. But I first met him at 14 years of age. And he had 3 months history of abdominal pain, loose stools, weight loss. He was anemic with elevated CRP. And we evaluated him with endoscopy and colonoscopy, and we saw a very inflamed terminal ileum with ulceration and irritation. And family wanted to avoid medication. And when we first saw them, we were just starting out our research and clinical work in this area. But we worked with the family, and they decided to go on to EEN, or exclusive enteral nutrition, and then go to the SCD. And he maintained clinical remission and laboratory remission for actually over 5 years. We repeated the endoscopy and colonoscopy, which we do for all of our patients to make sure that there is mucosal healing. And we saw a normal terminal ileum. And the biopsies came back completely normal with normal histology, just emphasizing the impact that diet can have. So the dietary advice that we give to our individual patients, it varies because every individual is coming in at a different ability, different desire, different needs in terms of their disease. And so we modify that for the individual. For those who are primarily focused on medication therapy, we really emphasize the importance of an overall healthy diet. But those who want to utilize dietary therapy as a primary therapy, we will use the SCD or modified SCD. So in conclusion, diet matters. It matters in Crohn's disease and ulcerative colitis, but it also matters for all of us. Thank you very much.
Thank you so much. And we have about 12 minutes for questions. So those of you with questions or comments, you can feel free to unmute or type in the chat box, and I will be ready to ask it on your behalf. Thanks.
Hi. Is it okay if I ask a question?
Absolutely. Tell
So
us who you are.
my name is Sarah. I'm one of the second-year pediatrics
Hi, Sarah.
residents. I know we draw like a very bright distinction between our inflammatory bowel diseases and sort of functional GI disorders and IBS type of symptoms. But I'm curious if similar therapies like this modified carbohydrate diet have been used in patients with more of like an IBS kind of picture. I know the FODMAP diet is used for that, but I was curious about like this specific carbohydrate diet.
Yeah, no, so diet is complex, but is integral to therapy. So there are many different dietary therapies that we could use for IBS. Diet absolutely has impact on how your GI tract feels. Initially, utilizing things like dairy-free or lactose-free diet, low sugars. We get a lot of sugar in our diets these days, low caffeine, and then moving towards the FODMAP diet if those initial diets modifications don't work. The SCD itself has not been studied in IBS, and although, again, we always try to balance out the pros and the non-pros of anything we do, and dietary intervention can be difficult. So if it were IBS, I would probably start off with kind of a focused dietary intervention versus a expanded one such as the SCD.
Thank you. I see some questions in the chat, so I'll ask this one from Dr. Pasloff. Thank you so much for that wonderful talk. How many of your patients are able to sustain the diet long term? It seems challenging for teens to stick with dietary restrictions, unfortunately.
No, absolutely. I think it's difficult for any of us to sometimes follow dietary interventions. I think that is one of the reasons that we have been studying how we can modify the diet and still get positive efficacy. I would say approximately 5% of our patients are on a SCD or modified SCD diet. So it's definitely not the vast majority. But I think this research really emphasizes the importance of diet in general for our patients. And so from this research, from the CDED diet and others, we are able to confidently say, try to remove the highly processed foods, try to remove the high sugar foods, try to decrease dairy to improve how you feel, as well as that inflammatory burden.
Thank you. A couple of other great questions from Peter Colrose. Great presentation. Does diet affect inflammatory markers for inflammatory diseases of other organ systems?
It's a great question. So there is some evidence that diet does affect other conditions. There is some research actually coming from the Netherlands that looked at the use of EEN on JIA and actually had some very positive results. And this researcher is now studying the SCD in her patient population. So there are other dietary interventions. The difficulty with dietary research, and one of the reasons it's probably not done as much, is that you're less able to control all the factors within. Education in terms of nutritional intervention is hard. When I say SCD and I describe it, a patient may hear what I'm saying, but not completely understand. So there's a lot of education that is needed with these research studies. So what I would say is yes, but definitely not as many research studies have been done outside of the realm of IBD.
Thank you. From Dr. Warner Grant. Hello, great talk. Sorry if you addressed this already, but are your EEN patients being affected by the current formula shortages and recalls? Are there ways providers can help make sure critical formulas for patients in certain populations are preserved for the ones who will benefit the most?
Oh, absolutely. So the answer is we have not had issue as of yet, but it would be very difficult if a family really wanted to do this intervention and we're not. We actually have just finished a study, Dr. Daly, myself, on something called reversed engineered EEN. And in that study, we utilized whole foods. And we actually gave a blender and Amazon gift card to patients. We blenderized whole foods, which was a complete nutritional intake, and we saw very similar efficacy as in the standardized formulas. So there's a lot of research that needs to occur to really understand why we're seeing such impact with nutritional interventions. But I think that's one of the exciting aspects of IBD research right now in terms of understanding that mechanism. And we're doing that as well. We're looking at the microbiome as well as the metabolome in these patients.
Great. And it looks like there's some parents on this call, some of your patients maybe. Hello, doc and entire team. Fantastic presentation. My 12-year-old was diagnosed with Crohn's in December. The disease is in her colon specifically. Currently, she's symptom-free on steroids and AZAK. Question, is there an STD version for vegetarians? She refuses to eat meat.
Yeah, it's difficult. The SCD definitely restricts grains, which is a great area in terms of getting proteins if you're a vegetarian. And so restricting meats as well makes it quite difficult. There have been some families who have integrated dietary intervention and being vegetarian, but I always worry about when you eliminate too many food options, assuring yourself getting all the nutrition you need, as well as the stress that can cause for some of the kids. So what I might suggest, if you are interested in exploring that, is definitely talking with a dietitian to see if that is feasible with what your daughter likes to eat, as well as reaching out to other families to see if they've had that experience or have been able to do that as well. I think it's quite difficult the more foods you remove from your purview.
Thanks. Similar question from another parent about the lower age limit for safety for the SCD. This is a 4-year-old, and the family is wondering about the safety for someone so young to be on SCD, or would modified SCD be more appropriate?
Yeah, and again, I think it depends on the individual, and that's why whenever we talk about dietary intervention, it's so important to have your physician as well as your dietitian involved in the decision making. We definitely have had young children on the SCD and do extremely well. Actually, in some ways, sometimes it's a little bit easier because you have control over their entire dietary choices. With that being said, again, you needing to meet with the dietitian to assure that an individual is getting complete nutrition, and that's one of the concerns whenever we deal with exclusion diets. But yes, we have definitely treated younger children with dietary intervention successfully.
Thank you. Quick question about calcium. How do you provide calcium while restricting calcium? Restricting.
So you get calcium in many, many different forms. And again, that's where the dietitian plays a great role. I do just in general have a website which kind of explains how to integrate in dietary intervention. It's called nimble.org, NIMBAL.org. And there are definitely resources on that page or on that website that can help sometimes families with integration of the dietary intervention. But calcium is in a lot of other products outside of dairy and milk. But you also are able to have hard cheeses as well as yogurt fermented over 24 hours, which again takes out all the lactose.
And are they allowed to have calcium supplements, just not dairy? Is that right?
Correct. And actually, there's a page on the website which talks about different supplements that are what we call SCD legal.
Okay. Thank you so much. There's so many more questions, but we have time for one more. So I'm just going to go in order. And thank you, everyone, for your questions. And thank you, Dr. Susskind, for answering them all. Fascinating topic and great presentation. Some patients see improvement with the diet and some don't. If a patient sees improvement to begin with, but then plateaus, is that to say the diet will no longer continue to improve symptoms, or will it take longer to continue to offer improvement?
No, it's a great question, and it's one of those issues that really important to kind of focus on, because no therapy, whether it's a dietary therapy or a medication therapy, no therapy works for everybody, and that's important. And so following up and making sure that you're following not only symptoms but inflammatory burden as measured by markers is important for long-term positive good outcomes. And so if somebody is not responding to a therapy, whether it's dietary or medication, we need to think, how do we get that person to do better? And sometimes if somebody wants to do or has tried SCD and it's not working, but really still wants to do dietary intervention, sometimes we go to EEN, get them into remission, and then go to the SCD. But again, this is always a discussion that you want to have with your GI doc.
Great. Thank you so much. And I put the website that you mentioned in the chat for everyone to see, but it's 9 o'clock, so I need to let everybody get back to their Thursday. So thank you so much to our audience for being with us and asking such great questions. And thank you especially to Dr. Suskind and your team for all the wonderful work that you're continuing to do to help everybody who needs you. So we really appreciate your time this morning, and thank you so much for an awesome presentation.
Great. Thank you so much. Have a great
We'll see
day.
everybody next week. Have a good day.